Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, everyone. I want to thank you for joining us for this very exciting and also very practical webinar on how to help our patients with biliary tract cancers. I want to start by thanking our partners here, American Liver Foundation, Digestive Cancers Europe, and Medscape Global Oncology for bringing us together for this education. It is my distinct pleasure for doing this program with my friend and colleague, Dr. Shubham Pant, who's a professor at the University of Texas MD Anderson Cancer Center. He is in the Department of Gastrointestinal Medical Oncology and in Investigational Cancer Therapeutics. I myself, my name is Lipika Goyal, and I'm the director of our Gastrointestinal Oncology program at Stanford. Today, we'll be talking about applying recent data to your everyday practice in biliary tract cancers. So I want to start off by saying that for a long time in biliary tract cancers, all we had was chemotherapy, and that was for about 10 years. In the last 3 to 5 years, we've really started to understand this disease more fundamentally, and this has led to more FDA approvals of different drugs. And so this particular webinar is focused on HER2 positive biliary tract cancers because there have been a couple of recent FDA approvals that we can apply in the clinic, and that's what we're going to focus on here. So as we all know, biliary tract cancers, there are 4 different types. There's intrahepatic cholangiocarcinoma of the bile ducts that are beyond the secondary radicals in the biliary tree. We have extrahepatic cholangiocarcinoma, which includes perihilar tumors, which are right here at the bifurcation. They're also called Klatskin's tumors. And then tumors of the distal bile duct are also extrahepatic cholangio. Gallbladder cancer and ampullary cancer are 2 other biliary tract cancers. And you can see the percent of patients with HER2 positive intrahepatic cholangio versus the others is different. Lower in intrahepatic cholangio, highest in gallbladder cancer. In gallbladder cancer, it's up to 30 to 36% in some series. So really important to be checking for this in all of our patients. So as I mentioned, chemo was the mainstay of treatment for anyone with advanced disease. So anyone with unresectable or metastatic disease, we used to use gemcitabine and cisplatin pretty much universally for all of our patients. But more recently, the combination of gemcitabine, cisplatin, and durvalumab beat out gemcitabine and cisplatin. And similarly, the combination of gemcitabine, cisplatin plus pembrolizumab beat out gemcitabine and cisplatin. And so immunotherapy has finally come to biliary tract cancers. And this triple regimen has now become the new standard for patients with advanced biliary tract disease. The median survival, as you can see, is still around 13 months. We'd definitely like that to get higher. So with some of these next line targeted therapies, we're improving overall survival. Unfortunately, in the second line, all we have for people who don't have targets is FOLFOX or other chemotherapies such as FOLFIRI and 5-FU Biliary. FOLFOX, when you compare to active symptom control, gives you about a month difference in median overall survival. So certainly a regimen that has some efficacy, but we'd like to do better. So now with the targeted therapies, we are giving people longer than 6.2 months in terms of the median. So that's great. So let's start off with a case because all of us as clinicians, we all get engaged with how we can help patients. So this is a 60-year-old man who received a diagnosis of metastatic gallbladder cancer and involved both lobes of the liver, and the patient also had lung metastases. Overall, good performance status at 1. He got first-line therapy with triple therapy, gemcitabine, cisplatin, durvalumab, and this led to a decrease in CA 19-9. But then the tumor marker started to rise and the scan showed progression. On profiling, the tumor showed HER2 3+ positivity when looking at IHC, immunohistochemistry. So Dr. Pant, this seems like a typical patient in your clinic, progressed on first-line therapy, looking for second-line options. You see that HER2 positivity. How do you think about this patient?
Yeah, thank you so much, Dr. Goyal. And it's truly an honor to co-host this program with you. Really excited about it. So I think the first thing is What I tell folks is that if we do not test, we will not find. So we really need to do, HER2 IHC, and we'll talk about it later about why IHC is important. And we also need to do next generation sequencing. From a decade back, we hardly used to see any NGS. When folks used to come to us in clinic, maybe a few had NGS, but now a lot of folks are doing next generation sequencing. And not only for HER2, you can get, FGFR fusion, in which we have drugs approved, one of them thanks to you. We also have ivosidenib for IDH1 mutation. So there are different drugs which are out there for certain mutations. So we really need to test for that. We can also catch other things like MTAP deletion and KRAS mutations, in which we have trials coming. So that's kind of overarching of way of saying, please do test. And sometimes, tissue is the issue with biliary tract cancers. And then we can do a ctDNA, but I always try to chase it down. That means if there's a biopsy for diagnosis and we don't have enough tissue to do an NGS, then I try to do a ctDNA. We don't have enough tissue there, then I always try to biopsy something to get enough tissue to do an NGS, because that can really change the trajectory of care for our patients. So the main thing is that we should test these patients, try to get their next generation sequencing. As you said, frontline, we've made some strides. We need to do better with gemcitabine, cisplatin, with either durvalumab or pembrolizumab. Second line still remains a space where our patients really do not get that benefit, but newer targeted agents have been, are showing this improved benefit. HER2 3 plus, they are agents now which are in the NCCN guidelines and which are approved, that we are going to talk about, that we can use after the frontline setting. So I think it's very important to test. Now, coming to this patient, they've already had immunotherapy. So what I would do in this patient is potentially put them on a HER2 targeted therapy, and we'll talk more about that in the future slides.
Absolutely agree with everything you said. And just to reiterate Dr. Pant's point about testing, if you don't look, you can't find. As he was also saying, we often don't have enough tissue to, not often, sometimes we don't have enough tissue in biliary tract cancers. The good news with HER2 is you actually just need a slide in order to be able to check for HER2 expression, because you can do immunohistochemistry the same way we check for CK7 and CK19, etc. It's just a slide to look for HER2 expression. So that's one quick and dirty way to look for HER2 expression. Right now at Stanford, we now have universal testing of all patients with GI cancers. It's reflex to do mismatch repair protein expression testing, and then also HER2 expression. Dr. Pant, at MD Anderson, do you also have universal testing?
Yes, we do. For all our GI cancers, we do the same thing. We do the testing for mismatch repair and for HER2, again, because of the importance of really finding targeted therapies for our patients.
Yeah, because otherwise, if it doesn't trigger for you as an oncologist or as a APP, the patient comes to you and you maybe forget to ask for that extra HER2 testing, but it's already there. Then you're like, oh, the patient has this, I have another option. So IHC is one way. As Dr. Punt mentioned, next generation sequencing. So there are lots of companies that do it. A lot of people have in-house panels, but that's to sequence the DNA and take a look, does someone have HER2 amplification? And you'll see for some of the trials, they required HER2 overexpression by IHC. Some of them required HER2 amplification by NGS, but both of these are good predictors of who's going to respond. And there are different levels of HER2 overexpression. We're going to talk about that later too. Dr. Pant, you check for HER2 in a lot of your patients. What are some of the challenges you're facing in the clinic when you just check for this?
Yeah, so that's why I did not take up pathology, right, as a profession, to oncology. With due respect, I love my pathologists. But again, they've got a tough job, right? Because when they're checking for HER2, the traditional way to check is the breast cancer way. But in biliary tract cancer, we're doing more gastric cancer because the staining is a little bit different of the completeness of the staining. So I won't go into the details of it, but you should check kind of multiple blocks in a way. And the staining is a little bit different, that they can call with less staining a HER2 3 plus in something with gastric cancer than with breast cancer. So I think there are like nuances there, but we're using more about the gastric cancer staining. Hopefully we'll develop HER2 staining for biliary tract cancers once we have more data, more samples. So I think that's one of the next steps. But right now we really, talk to our pathologist, make sure, whatever blocks we have been tested.
Yes, absolutely. And also to reiterate, all these drugs that are approved and everything we're talking about today are tumors that have HER2 overexpression or HER2 amplification. There's also something you pick up on NGS, which is HER2 mutations. And there's certainly drug development out there for HER2 mutations, but in biliary tract cancers, we don't yet have anything approved for this in particular. Okay, so how do we generally approach this? Patients have their tumor tested by the pathologist with immunohistochemistry testing. If they're IHC 0 or 1 plus, done, no HER2 inhibitor. If it's equivocal and the immunohistochemistry is 2 plus expression, then we go on to do FISH testing. If the FISH is positive, then we go on to consider HER2 targeted therapy, and we'll talk about this population of patients specifically. This is the money population right here. Anyone who has 3 plus HER2 staining, those are the people that respond the best to the HER2 inhibitors. Definitely with these patients, we want to consider a HER2 inhibitor. So overall, it's a multidisciplinary process. As mentioned, we have reflex testing. It'd be great to see at your institutions if you can get reflex testing for HER2 if you don't have it already, because it's a great way to identify these patients, avoid delay, and then educate patients early about thinking about HER2 inhibitors in the second line. So what are the guidelines right now? In terms of FDA approvals, there are 2 drugs that are FDA approved. There's trastuzumab deruxtecan, which is an antibody drug conjugate. That has a tumor agnostic approval. So just like pembrolizumab has a tumor agnostic approval for MSI high tumors and mismatch repair deficient tumors, and some of the RET inhibitors and NTRK inhibitors are tumor agnostic. TDXD is for any tumors that have IHC 3 plus for HER2 testing, any solid tumor. Zanidatamab is only FDA approved for biliary tract cancer, and this is also for IHC 3 plus. EMA in Europe, this approval is pending. 2 other regimens that are on the guidelines but don't have FDA approval are pertuzumab trastuzumab and tucatinib trastuzumab. Dr. Pant will go over in detail the data from the trials that led to these approvals. Overall, these are the 2 championed by the ESMO guidelines. The NCCN guidelines don't make a distinction between these 4, but of course, these are the 2 with the strongest data that have FDA approval. So turning it over to you, Dr. Pant.
Thank you so much, Dr. Goyal. So this is an easy slide that we've seen a lot of different times. So in HER2 binding domain, you can bind to the outside of the target. So trastuzumab binds to something called extracellular domain 4, and pertuzumab binds to extracellular domain 2, and then tucatinib kind of gets inside the cell and binds to the ATP pocket. And these are the way it disrupts cell signaling. So again, leads to the death of the tumor cell. So moving on to the trials, it's important to note the differences in these trials. So I want to walk you through this. So if you look at my pathway or pertuzumab and trastuzumab, this is part of a basket trial. 39 patients had biliary tract cancers in this, BTCs. And the overall response rate is about 23%. And then you come to trastuzumab tucatinib trial, which is again part of a basket trial. It had 30 patients with biliary tract cancers, and the response rate was 46.7%. And then for second line, there was another trial with 34 patients, but this was a standalone trial for biliary tract cancer patients, which was trastuzumab with FOLFOX. The response rate was about 30%. And then you had another trial called the TAB trial. Now, this is different from the other trials because all these other trials were done after frontline therapy. This was done in the frontline setting. More than 90%, almost all the patients had gallbladder cancer. This trial was done in India at a single center, which had trastuzumab, gemcitabine, and cisplatin. The response rate was high, but remember, this was in the frontline setting. And as you can see, the progression-free survival was fairly similar, right? About 4 to 6 months of progression-free survival, and then median overall survival from 10 to 16 months. But again, these are all basket trials other than a couple of trials that I've talked about. So you cannot do cross-trial comparison for them. Now, coming to some of the safety signals, the trastuzumab, pertuzumab, that fairly safe regimen, we've given it for different things. We've been giving it for biliary tract cancers. It's been given a lot for breast cancer. Tucatinib, trastuzumab, the main one you need to think about is diarrhea with these agents. Then you have the trastuzumab on FOLFOX, and then you have the trastuzumab gemcitabine cisplatin, which is very similar. Majority of the side effects are attributed to chemotherapy in these regimens. Now, coming to mechanism and structure of TDXD, It's an ADC. It's almost like a smart bomb, right? It gets stuck to the cancer cell and releases the payload. In this, it's the topoisomerase 1 payload, which is released into the cell, causing cell destruction. So these are, highly effective agents, which started with breast cancer, as most of these drugs start with HER2, and then kind of have found their way to other cancers now, and other cancers like more GI cancers. This was the Destiny Pan Tumor O2 study. Again, this was a basket trial. Patients had HER2 3 plus or 2 plus, like Dr. Goyal said, and the ECOG was 0 or 1. And again, this is how the local and the central testing of HER2 was done. These authors did look at concordance and discordance. That means when you did it locally, how much was the difference than centrally? And it was mostly concordant for 3 plus. So 2 plus are a little bit tricky because kind of beauty can be in the eyes of the beholder. So there was a little bit of discordance with the 2 plus, but most of the 3 plus were concordant. The overall response rate was in 3 plus 56%. If you had HER2 2 plus was 0. And there were about 16 patients with HER2 3 plus in all 30 patients with biliary tract cancers were included in the Destiny Pan Tumor O2. So, Dr. Goyal, what do you think about this HER2 3 plus and 2 plus? We see these great responses in 3 plus and not so much in 2 plus. What do you think about that?
Yeah, I think this is a really important point to highlight in this webinar. It's just that when you see the 3 plus, I absolutely go for a HER2 inhibitor because we do see a lot of activity. In the 2 plus, I'm just not sure it's necessarily worth the toxicity. You can see the response rate there was 0%. You can see the PFS is 4.2 months, which is very similar to what we're seeing with FOLFOX. And so when I see 2 plus, and again, all these patients were FISH positive by amplification, to my understanding. Dr. Punt, correct me if I'm wrong, but they're all FISH positive. So it's really the 3 plus that benefit. And with the 2 plus, I really think twice about giving this regimen.
If we take any take home from this webinar is test everyone. That's the first thing. And the second thing is think about the overexpression, which is about 3 plus the approvals of TDXD and zanidatamab. When I give trastuzumab deruxtecan in the clinical setting, it's like, in a way, giving chemotherapy. Patients do experience some side effects. Fatigue and nausea are the main ones that I see in clinic that patients talk to us about. But we obviously see neutrophil count decrease and anemia, which are the other side effects. But a side effect which we really have to watch out for is interstitial lung disease or pneumonitis. So it's very, very important to see this because it can lead to death in rare circumstances. As you can see, one patient died on this because of interstitial lung disease. So that's very important to follow in these patients. Coming to kind of the newest kid on the block, I guess, zanidatamab is bispecific HER2 antibody, binds to the two targets that trastuzumab and pertuzumab bind to. So it binds to ECD2 and ECD4. It's kind of two drugs in one and leads to maybe better binding. And that leads to maybe, ADCC and slowing tumor growth, maybe more efficiencies. And this was a trial called the Horizon BTC01 trial. This was a unique trial because it was only in patients with BTC. There were 80 patients in it with IHC 2 plus or 3 plus. Zanidatamab was given IV once every 2 weeks with the primary endpoint of overall response rate. The overall response rate for HER2 3 plus was about 52%. Overall response rate for when you take the whole study with HER2 3 plus and 2 plus was about 42%. So again, the benefit was being driven by the HER2 3 plus patients. Interestingly, in this study, the duration of response, that means once you start getting a response, patients did tend to stay on for a longer period of time. The duration of response was about 14.9 months. Median overall survival in HER2 3 plus was 18.1 months. And this is after frontline treated. So this was fairly robust in these patients. So really, this is a true driver of the disease that we can see. The main side effect is diarrhea. There were some infusion-related reactions. In the beginning of the trial, we didn't pre-medicate. We saw kind of a higher rate. But once we start pre-medicating, the percentage is very low. But this patients do need pre-medications from day one.
In terms of patient selection for these two, I think the safety profile is really important. So Shubham, what have you seen in terms of the safety profile of these two regimens?
There are different side effects. So diarrhea is the main side effect than zanidatamab, so you have to watch out for that. If you give patients Imodium, you can control the diarrhea with that. Infusion-related reaction, but if you pre-medicate those patients, that percentage is low. For trastuzumab deruxtecan, it's more, before I give them the therapy, I tell them you can get the nausea, you can get the fatigue, and then obviously I watch out for interstitial lung disease. Remember, this is one of those rare ones that even with grade 1, you have to hold the treatment. So you've got to be very careful in analyzing your patients. I always ask them leading questions. If you couldn't walk so much, can you still walk up the steps? Do you get winded? If I see some change in the CT, I'm instantly alerted to that. So different side effect profile. And I think really you have to look at every individual patient before you take a call about, what could you treat your patients with. But it's good to have more options for our patients. So I'm really excited about that.
Yeah. Can I ask you one question about the infusion reactions for Zani? It seems like one key difference is Zani has more infusion reactions, trastuzumab deruxtecan has more interstitial lung disease. For the infusion reactions, do you often just see it on the first dose and then you pre-medicate and then it goes away? Or do you see it from multiple doses? Can you tell us a little bit about that?
Great question. So we normally just pre-medicate from the get-go.
Great.
And then it's rare to have those infusion reactions. So, Evika, we've got a few minutes left before we ask for questions. So, how would you treat these patients? I can answer that. You can use either one. You can use zanidatamab or trastuzumab deruxtecan based on physician choice, I guess. Both are great choices. What factors in your treatment decision, Lipika?
One big question I would ask is, did they have issues with their counts on gemcitabine, cisplatin, durvalumab? If they had issues with their counts, it seems like trastuzumab deruxtecan maybe caused a little bit more because it's like chemo, cause more issues with counts than zanidatamab. And then also find out about in terms of their GI tract and their lungs. Do they have any underlying lung issues or do they have a lot of baseline GI issues?
Yeah. I want to talk about quickly about how important patient involvement is in decision making. And I think for me, and I know Lepika, for you, ours is more shared and collaborative. We really talk to the patient, their families, about seeing what they want, what their choices are, what they really want to do, and kind of really individualize the treatment to the patient. So I think shared decision making, that's what I try to do for my patients.
Absolutely. When you have two good options, it's definitely worth sharing the efficacy data, the safety data, and coming together to have something that suits the patient.
Great. So, I'm going to summarize saying HER2 is a validated target in BTC. Please do test. If you don't test, you won't find. You have zanidatamab that received accelerated approval for recurrent advanced or metastatic HER2 positive IHC 3+, BTC from FDA in November 2024. EMA decision is pending. TTXD agnostic from FDA in April 2024, again for recurrent advanced metastatic HER2 positive, 3+. And then you also have trastuzumab, trastuzumab tucatinib, which are guideline recommended. Again, there are a host of new agents coming out. Super exciting time for our patients. Really, interested to be in this field. So with that, we'll take any questions. Because I've been doing all the talking, Lipika, I'll give you the first question.
Yeah, of course. So this is a great question. Is there anyone with HER2 positive biliary tract cancer that you would not use second line HER2 inhibitor? So one, those HER2 2+ folks that are FISH positive, I'm less inclined to use a HER2 inhibitor in those folks. But then also people who have cardiac problems. So if people have a low EF, like 30%, 40%, because there's a high risk of cardiac toxicity, it's definitely one of those pieces where you do shared decision making with the patient. Shubham, when you see an EF of 30, 35%, is that like an absolute contraindication to you for using Zani or trastuzumab deruxtecan?
That's a tough one. Yeah, I mean, it's tough. That's just low. That's more maybe chemo. I would follow them very closely. That's definitely very challenging. The other ones are the ones which really have a poor PS. Not every patient needs to be treated in second line setting. Once they have a poor performance status, maybe of 3, and they have multiple comorbidities, then that's the other one that potentially I would wait for.
The next one is, can you switch to a different HER2 therapy if the patient doesn't tolerate one that they're on? I think that's a great question. And my answer is yes. It could be that their tumor is just not driven by HER2 and that's why they didn't respond. Or it could be that for whatever reason, the tumor is going to be more likely to respond to one HER2 inhibitor over another. We certainly did see in the initial studies of TDXD and zanidatamab that people had benefit after they had progression on a prior HER2 inhibitor. It could also be someone had toxicity on one drug and they're going to tolerate the other one. So yes, I would consider switching because HER2 is definitely a driver in some of these cancers.
And I 100% agree. This is definitely a prognostic marker. There was a big retrospective review published from South Korea and from MD Anderson at ASCO GI. And definitely there is data that it is, poor prognosis if you do not treat with HER2 target therapy. So it's important if they're not tolerating to switch if you can.
Shubham, I know you have these trials at MD Anderson. Do you want to talk about the frontline randomized
There
trial?
are two frontline randomized trials, one with TDXD with their PDL1 and TIGIT antibody. Frontline, their patients are randomized to TDXD with the TIGIT is called Rilvi, and then the second is TDXD and Gemcis Durva. The zanidatamab is a different trial called Horizon BTC02, which is Gemcis, Durva, or Pembro with or without zanidatamab in frontline. So super excited about moving both these drugs to the frontline setting for our patients.
Yeah, I would really love to get HER2 into the front line because we know a lot of our patients don't get to Plan B. They don't get second line. So if you see someone and someone has HER2 positivity right off the bat, please do take a look and see if there's any of these centers near you where you can refer patients.
All right. I think with that, we can wrap up our program. Thank you so much. And thank you, Lipika, for leading off a great discussion.
Thank you very much. A real pleasure and real honor to do this with all of you.